Good afternoon, everyone, and good morning to those of you on the West Coast. Thank you all for joining us today for our webinar discussing the role of pelvic floor health in colorectal cancer survivorship. My name is Zach Getty, and I am the Patient Education Program Manager here at FIGHT CRC. FIGHT Colorectal Cancer is the leading patient empowerment and advocacy organization in the United States, providing balanced and objective information on colon and rectal cancer research, treatment, and policy. We are relentless champions of hope focused on funding promising, high-impact research endeavors while equipping advocates to influence legislation and policy for the collective good. Before we get started with the webinar today, let me go through a couple of housekeeping items that we do with every webinar. So you will have some time at the end of the webinar for questions. We're hoping to get about 15, 20 minutes or so in for questions at the end of the webinar, but feel free to use the Q&A panel on the right side of your screen to ask any that come up along the way. We will do our best to address them at the end of the presentation. We will have the recording of this webinar available on our site in the next few days, and you will receive that direct link via email as soon as it is available to the email that you use to register for this webinar. And last, please feel free to tweet along with us. You can use the hashtag FightCRCwebinar. Please remember to stop by our website at fightcrc.org to check out all of our patient and caregiver resources. These include, but are not limited to, your Guide in the Fight meetups, which are online space to meet with other patients and caregivers, which are held 4 times per month. Our free Community of Champions app, where you can connect with other people in the colorectal cancer community, and an assortment of print and digital educational resources that are free to request and download. And just as an aside, since we've seen such good take-up for this webinar and registration numbers, our Guide in the Fight meetup on September 14th at 8 p.m. Eastern will actually be kind of a continuation of the conversation that we hear today. So if you're interested in talking to other people about pelvic floor health, about what your experience has been, please feel free to register for that Guide in the Fight meetup, and you can do that through our Community of Champions app, which is available on both iPhone and Android in the App Store or Google Play Store. Next, I just have a little disclaimer. The information and services provided by FIGHT Colorectal Cancer are general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you are ill, please see a doctor immediately, and in an emergency, call 911 or go to the nearest emergency room. FIGHT Colorectal Cancer never recommends or endorses any specific physicians, products, or treatment for any condition. And with that out of the way, I'd like to briefly introduce our participants. Joining us today are Dr. Eileen Johnson, physical therapist at USC Physical Therapy, and Danielle Ripley-Burgess, chief storyteller here at FIGHT CRC and 3 times colorectal cancer survivor. Thank you both so much for taking time out of your schedules to join us today. I'm going to hand it off now to Dr. Johnson and Danielle so they can introduce themselves a little bit more thoroughly and get this webinar started.
Thank you, Zach. So I am here from a patient perspective. Like Zach said, I have had multiple surgeries and diagnoses, and so excited, Dr. Johnson, just for you to be here and learn from you. So I'm not going to take up too much time right now because I want to get to all of your awesome slides, but I want everyone out there to know I'm going to be taking notes and asking some questions at the end of her presentation, and then make sure if you guys have questions, put them in the QA box and we'll get to just as many as we can.
Thank you. Thank you everyone for having me here today. Again, my name is Eileen Johnson and I am part of USC's physical therapy team, specifically specializing in pelvic health. So my discussion today is going to be more geared towards pelvic health and the pelvic floor muscles and their role in colorectal cancer survivorship. I have been at USC for 10 years and practicing for about 14 years, all in pelvic health. This is an area that I'm really passionate about, and sharing knowledge is so powerful. So I hope that everyone gains a lot of new information from this talk. There's so much more I could have added, but again, I just focus on more pelvic health, and hopefully there can be more discussions to follow. But you can see here the list of objectives I want to achieve with this talk. Again, understanding the role of the pelvic floor muscles, and then possible changes that occur after colorectal cancer treatment, specifically focused on LARS. And then I want to help improve your awareness of the pelvic floor rehab. So knowing what interventions exist, what it might look like to go to physical therapy, what to expect, and more importantly, empower you with knowledge so that you have some evidence, some knowledge, and education on how to advocate for your own pelvic health after this talk. So let's begin with the pelvic floor muscles. You can see here, they are right at the bottom, right here, but they are part of what we call our core. So our core is basically the deep abdominal muscles, these transverse abdominis muscles that span from the front all the way to the spine. Your respiratory diaphragm at the top, these small muscles along your spine, your multifidus, they stabilize your spine. And then the very bottom, the floor of your core is your pelvic floor. And that's the group that we'll be focusing on majority of this talk. And they have 4 roles. They have a sphincteric function. So they're able to close, relax, to empty that muscle as like a sphincteric movement. They support the pelvic organs. So again, just like a hammock, they span from the pubic bone in the front all the way to the tailbone, the lowest part of your back, and support all the pelvic organs. They have a role in sexual function, and just like the core, they have a role in stabilizing the pelvis and the trunk. Here's a top-down view of all those muscles. There's so many muscles and so much fascia that are intertwined that form your pelvic floor. But I like this picture because it really shows just how intricate and how many little muscles make up our pelvic floor muscle. And again, these muscles help stabilize our pelvis. So that can lend to treating low back pain, hip pain. If the pelvic floor isn't addressed, sometimes things can be improved when the pelvic floor is also addressed. I'll put it that way. Female anatomy, you can see here the muscles spanning from the pubic bone again to the tailbone support in female anatomy the bladder, uterus, and the rectum. And there's a superficial layer of muscle and a deeper layer of muscle as well. So looking at the pelvic floor on all the different layers of the pelvic floor is what we'll look at in PT. For male anatomy, you can see that there is very similar, but again, bladder, prostate, seminal vesicles, and then the rectum that are all supported by the pelvic floor. And this, just like the female anatomy, a lot of this is very similar, just a little bit different in anatomy. But same, we have that superficial layer at the base of the penis, and again, around the anal sphincter. And you can really appreciate that sphincteric quality to the muscle in this image too. So for the general population, pelvic floor dysfunction is highly prevalent. 1 out of 4 women experience pelvic floor dysfunction in their lifetime, 1 out of 10 men. And you can see 16 million adults are affected in the United States. And sadly, only 1/3 of those will seek help. And lots of dollars are put into treatment, whether it's through medication, through sanitary products, pads, hygiene products. There's a lot of money that is spent to treating pelvic floor dysfunction, or the things that come along with pelvic floor dysfunction. For the oncology-specific population, I did include some stats, but I will focus on, again, bowel, but I did include some pain and some urinary incontinence symptoms as well. And then fecal incontinence, again, prevalence estimate between 2 to 37%, with the rates of monthly or more frequent fecal incontinence being 26% after any radiation therapy. So that's another component that we want to consider as a provider, looking at the patient's history and knowing all that was entailed in cancer treatment. radiation therapy can also make an impact to the tissue. In regards to bowel dysfunction, lower anterior resection syndrome, as you guys may be aware, this is a big collection of symptoms for those who've undergone any kind of rectosigmoid rectal cancer surgeries. And the prevalence is pretty vast. So 19 to 90% prevalence. That's a huge range, but a high range. With up to almost half, 50% of patients experience symptoms at their 6-month follow-up visits. We also want to consider patients who have had partial ostomy post-surgery and some PT complications after that. I listed some of the risk factors that are considered going into surgery, and then as far as for LARS here. And then some of the symptoms that we treat in PT specifically are helping with fecal urgency, helping to reduce that amount of frequency of bowel movements or incomplete emptying, with that sensation of having to go after you just went, because there's some what we call stool fragmentation or this incomplete emptying that still gives that sensation that there's pressure in the rectum that stimulates the brain to feel like it has to have a bowel movement. And of course, fecal incontinence. And I'll mention too, flatus incontinence. A lot of patients I see don't only have fecal incontinence, but they have gas incontinence. So it's the same muscle that helps control this that we'll work on. And again, a huge impact on quality of life and their psychosocial well-being. So my patients who I see with these symptoms, they oftentimes, have stopped socializing. They've stopped doing the things that make them happy and seeing the people who make them happy. And I want to help them regain their function, regain their control, to get back to doing those things. So I'll work together with my patients and come up with a list of goals and knowing what they want to get back to, whether it's being able to go to their kid's wedding, go to their grandchild's, recital and sit through that, or go to the movies without this interrupting their life. These are the goals that we'll work towards. And maybe going back to, I had a patient who wanted to do a big hike. So doing things where they have to be out in nature, where a restroom may not be readily available. These are things that I want to know and I want to help my patient work towards. So this is some of the medical treatment that I listed here. Oftentimes patients are on antidiarrheal medications. There could be some bulking agents that may, again, make the stool form a little bit easier to hold back. And there's even things that can help improve the nerve function. But oftentimes we're going to look at more pelvic floor related treatments in therapy. And basically what some of the studies that are out there, they looked at 4 months, the total LARS and Corifo scores. These are some outcome measures that looked at stooling quality, how frequently someone had to have a bowel movement or experience incontinence. They improved 2 times as much as the control group at 4 months for those who did pelvic floor PT. And this was shown to help to reduce the average amount of bowel movements, the amount of fecal incontinence or episodes of fecal incontinence, and the average number of fecal stooling clusters per day, all through pelvic floor PT. Again, supporting that it should be like a first line treatment to help with bowel dysfunction after colorectal cancer surgeries or treatments. So now that I've talked all about it, now I'm going to kind of at least paint a picture of what it might look like at your first PT visit and maybe throughout your sessions. But at the first visit, like I mentioned, I want to get to know you. I want to get to know what's going on in your life. How is this impacting your life? So there's a lot of questions that we'll ask. I'm not going to go through all of them here, but just a little bit of a peek into what questions might be asked, because they are very intimate questions. but it does help us PTs gather more information on what's going on and how to better address your muscle health and function. And also how to incorporate other members of our medical team. I'm just one member of that team. We work with, the physicians, the nurses, the nutritionists, the occupational therapists, even other PTs within our clinic who have specialties in maybe more spine related or hip related issues. But we'll all work together as a team, but it takes a lot of data collection and information gathering in the first session, as well as knowing your surgical history, so doing that chart review as well. On the first visit, the first thing we'll do is look at your pelvic floor awareness. How well aware and how well can you find these muscles? So one of the most simplest ways of finding out how aware you are is looking at the muscle. So we'll use a camera, something not recording, just something to show as a big mirror, or we may use a handheld mirror and have it along the perineum. And so you're going to see your perineum. You're going to get to know where those muscles are. And I'll have you contract and relax. And we'll see how well you can find those muscle groups and isolate that movement. And so when I talk about isolating the muscles, these are some of the verbal cues that I like to use. So I want you to imagine like you're holding back your gas. Everyone has been in a situation where we've had to do this. Whether you're in an elevator or you're in a small enclosed space and you just have to hold it in, that's the muscle I want you to find. We've done this for holding in our urine during an urge. For men, clearing the line, anytime there's a little bit of urine still in the urethra, using those muscles to Kegel creates a back pressure, and that's what clears the rest of the urine in the urethra. And then it's also, again, has a role in sexual function. So when you do the Kegel, I should not be able to know you're Kegeling. And it's going to be a very small movement that is occurring. And then I'll watch for these common errors. So some people will Kegel and they'll hold their breath, or they'll do the opposite and bear down. And that's not what we want to do. We want to really think about pulling things up and inward and then relaxing it down and outward, and having that nice, smooth control and good motor control of the muscle. And we don't want to use other muscles such as the abdominals or the glutes too much where it overpowers the pelvic floor muscle, because there's a lot of muscles around the pelvis. These are some of the larger muscles, your glutes, your buttocks, your legs. Even patients I see, I'll be teaching them how to Kegel, and they're gonna be squeezing all the muscles in their face. So it's harder than one thing. Sometimes it takes a lot of just cueing practice and awareness training, especially after surgery. A lot of those nerves are kind of wondering like, what just happened to me? And we have to work on waking up the right muscles and those nerves that feed into the muscle to gain better control. So when that happens, sometimes we use other tools. This is an example of biofeedback, and not everyone needs it, but for some patients who really have a hard time finding those muscles, especially those who are visual learners, using a modality such as biofeedback can be very helpful. And what it is, this is a rectal sensor, and we have surface electrodes. We can do either or, but the rectal sensor goes into the anal sphincter. It's about the size of my pinky. And basically it has these sensors that read the electrical activity of your pelvic floor muscle and show it on a graph, okay? And there we can see what's happening with the pelvic floor. If the rectal sensor is not sounding as, like you're not ready for that, we can do surface electrodes as well, and putting those on the perineum to feed into and feel like see what's happening in those perineal muscles. So I have some examples of what biofeedback might look like. So the patient is having the sensor in, and they'll contract and they'll relax, and we'll see that graph go up and go down because it's reading in microvolts what that electrical activity of that muscle is. And one of the first things we'll do is do a little bit of endurance testing. All the evidence that goes towards fecal incontinence supports pelvic floor endurance is so important. So it's not just how quick and how many quick contractions you can do, it's about how long you can sustain that contraction and in a good quality manner. So this is a test where we have the patient hold their contraction for 10 seconds, relax for 10 seconds, because again, that muscle has to move both into a nice contracted state and then into a relaxed state. Both are equally as important. And then I'll have them do it 10 times. So in this example, you can see this is someone's pelvic floor represented. You can see they contract well, but then there's a little bit of this drop off. And over the repetitions, that peak is slowly going down. So there's a little bit of muscle fatigue happening here. Also a little bit of lack of endurance. It pops up and then it drops down. They try to contract again. Oh, it lets go again. So this could be a starting point, and we can train the muscle where eventually it performs like this. So you can see the difference. This person is a rock star and they can hold their contraction nice and evenly across all 10 repetitions. It doesn't fatigue, it doesn't go down in amplitude, and they can maintain that 10-second hold across where you don't see those big divots, those big drops, just with pelvic floor muscle training. I'm going to get into this a little bit later, but this is what we do a lot for patients who are having their ostomy reversal. So preparing their pelvic floor, which may not have been active and needing to be used for 6 to 12 months, and waking up those muscles and reminding them, hey, this is what your job is. And we need to be ready after surgery to do this again. So this is just a little example of what biofeedback looks like. We get into a little bit more finesse with the muscle, again, just to really train and get good motor control. So it may look like this is just a little template we have, but they are contracting and holding it, and then they're getting a little bit more and then relaxing partially, getting a little more, relaxing partially. So you're going to really be so good at controlling your pelvic floor muscles with again, this training. This is the hardest one. It's a pyramid. So again, learning how to fine tune how much you contract, and little by little building up, and then relaxing partially. And this is again a much longer hold than 5 seconds. We're going to try to do 10-second holds. That's going to be our gold standard. Sometimes 20 seconds, depending on the need. So if you don't go to PT, there are some home biofeedback devices that you can use. Unfortunately, no one has yet to create a internal sensor for males. There's one that a pad you can sit on and you can contract, and it can kind of read that movement, but I didn't include it because I feel like it's not as accurate. Oftentimes it's reading the glutes. But these are for females, home units that attach to your phone, and you can see here they have been very creative and made games. So like when you contract and relax, it has to go through these little mazes. You can again see just a graph. And then if this is a little bit intimidating, there's even weights. There are vaginal and rectal weights that you would insert vaginally or rectally, and then you could train the muscle and just get that feedback of, are you contracting in the right spot? Are the muscles able to hold? Not quite the same as doing resistance training with weights, but more so getting that feedback, that sensory feedback on your muscle, and feeling that muscle contract, and again, equally as important, relax, because we need to know how to relax the muscle in order to have a bowel movement. Another question I'll ask patients is, what does your stool look like? So sometimes with LARS, patients will have a across the board, but more often than not, it's going to be more on this type 5, 6, 7, more on the looser stool side. And we want to try to help the patient as much as possible, whether it's through dietary changes, stress management, exercise and movement, to be able to attain more of the type 4, 5. Type 3 might be harder just because of the surgery and how there's again, there could be a little bit more colon removed depending on the surgery, but as much of a normal form stool that we can get. And again, that's where the teamwork comes in. That's where working with a dietitian, working with the physician team, working with PT to get the muscle control all comes into that collaboration. And then most importantly, working with the patient. We do work on toileting techniques. So looking at how you evacuate does make a difference. Some people find it easier to relax the pelvic floor if their feet are on a step stool. And so this is just a fancy thing that's called the squatty potty, and it fits around your toilet, but you can use any step stool. Again, but that helps put the pelvic floor at a better angle to actually be more slackened and help the stool empty with much better ease. We also talk about breathing. So looking at breathing techniques and diaphragmatic breathing can make a difference as well. This is just a little bit more on that squatty potty, but if you can see here, there's that pelvic floor muscle. This is the puborectalis specifically that goes around the rectum, or that last part of the colon, and then it will be slackened when there's this position of a squat. And then the other component that we'll do in PT is take a look at the whole pelvis. So again, our bread and butter is working on all the joints, all the back pain, the hip pain. So we still incorporate all of that. Again, just specialized to the pelvic area. So sometimes patients after surgery may experience some scary symptoms that we can help demystify by looking and feeling what's happening. But there's definitely scar tissue that can form along the surgical sites, and that can impact some of these peripheral nerves. So patients may complain of, oh, I get this sharp pain traveling down my leg, or I get this sharp stabbing pain just randomly sometimes, or whenever I do a certain movement. And then that clues into me that, okay, let me look at their spine. Let me feel along their scars. Let me see what possible other anatomy might be involved, especially post-op. And that also means looking at all the muscles, looking at the strength of the abdominals that were, again, cut through during surgery, even if it was minimally invasive surgery, and looking at how all those deeper muscles are working as well. So it's looking at mobility of the tissue of the muscle, flexibility of the muscle in the hips, as well as the strength of the muscle. So lots of moving pieces. And then for patients who have more on the constipation side, we can teach them home programs, manual techniques such as abdominal massage, which I included here, especially if they're having a lot of, I see patients who experience a lot of bloating and discomfort after surgery. We'll work on just improving the mobility around the colon, and depending again on where the cancer treatment was and where the surgery was, it might look a little different, but in general, the colon is still going to move in this way. Different for ostomates, but I still do this same massage for patients who have ostomies, especially if they have any kind of recurring blockage or tension, or side effects even from chemotherapy that can alter the motility. This massage can also be helpful. And this is something that we teach in clinic. For a portion of the population I see with bowel dysfunction, sometimes it's not quite fecal incontinence, but it's more of this difficulty emptying and having those little stools that make them have to go several times a day. So the fancy word for having that incoordination with bowel movement is dyssynergic defecation. But in patients with chronic constipation, it actually is occurring up to 40% of that population. And thankfully, there have been really good studies that show that there's major symptom improvement in 70 to 80% of patients who get biofeedback therapy to treat this. So we working on learning how to control that muscle. Again, in this case, how to fully relax the muscle and how to evacuate more completely with that. And using your breath, using toileting postures, and pelvic floor coordination. And the nice news is that the long-term studies that are out there show that this is being able to maintain long-term, so greater than a year, in 55 to 82% of patients. So it's kind of like we want to really learn it and learn it well. Aside from biofeedback, some of the other things that we may do in PT for patients who have difficulty emptying are some of this balloon expulsion training. This is a balloon catheter that goes into the anus, and we will fill it with about 50 to 60 cc's of fluid, just to give that sensation of, okay, something is in my rectum and I need to know how to evacuate this. It's more functional training, in fact. So they will feel that pressure, and then we will incorporate the breathing techniques, the pelvic floor relaxation techniques, in order to evacuate and not strain and not push and not put more pressure down on those muscles or on the abdominals, which had, again, surgery as well. And then we will always send you home with a home program. So making sure that you have things to continue to practice at home. Just like the disclaimer said, these are just very general things that I included and wanted to discuss as far as working on relaxation. So these are some stretches that we may give, looking at hip openers. So working on the inner thigh muscles, especially if they've had radiation. A lot of times the tissue that had been radiated and the joint surrounding can get kind of tight and rigid. So we want to make sure there's good mobility throughout the whole pelvis. This is a more advanced stretch called a happy baby. For those of you who do yoga, you may have seen this, but again, it's going to work on stretching that inner thigh area as well as the perineal area and the low back. And again, this will be all patient specific. So I will see my patient in clinic, look at their range of motion of their hip, look at how their flexibility in their muscles are, and then from there, come up with specific exercises and stretches for that person. So again, more encouraging for you to see a therapist that can evaluate you specifically and give you what you need. But again, we can do stretches for the hips, the hamstrings, the hip flexors, even some of the muscles along the side of the hip. Again, even after surgery, doing some gentle movement is, again, under guidance is very important, just to get everything moving and helping your bowels to regain more motility. And for those of you who have an ostomy, same thing. We want to make sure that you have good posture, good flexibility, good movement, all safely and without any kind of strain on that incisional site. For some deeper restrictions, we may implement some foam rolling or use some stretching bands. And this is a great one for my patients with pelvic floor tension. Depending on your hip and your knee joint flexibility, we can do some deeper squats. Again, with the purpose of thinking about opening up the hips, relaxing the pelvic floor for patients who have difficulty emptying. For those who have fecal incontinence, oftentimes the misconception is that the pelvic floor is weak or is lacking sturdiness or strength or looser, but people can have fecal incontinence and fecal urgency if there's too much tension in the pelvic floor as well. So that's why the evaluation that we do in clinic helps us to better understand what the pelvic floor tone is like. And that involves a glove finger with lubricant into the vagina or the anus and feeling the tone of the muscle, just like we would examine someone's neck. Someone can have tension in those muscles, and because of that tension, they can't contract the muscle. If you imagine your pelvic floor is like a bicep, and your pelvic floor is nice and regular tone, normal tone, you can make a really big muscle. But if your muscle is already tightened and you try to contract and stop a leak from occurring, an accident from occurring, it doesn't make as powerful of a contraction. So that's why looking at the muscle and then both working on coordination to relax and contract and looking at the surrounding muscles is so important. Another part of the home program, aside from exercises, depending on what we find with tone, we can do some myofascial release with some of these tools. There are both vaginal and rectal dilators. I tend to use this for patients, again, especially if they've had radiation therapy and there's that tension or some rigidity in the tissue. We'll do some gentle work on improving the mobility with these dilators or trainers. This is a pelvic wand, so it can be used vaginally or rectally. And again, it's used to help do some internal massage to, again, restore that movement in the muscle. And again, radiation effects may not be seen immediately. It's sometimes seen later on as the years go on. So patients will use this, again, more as a maintenance program to make sure that there is no tension or scar tissue development that may be impacting the muscle performance later on. We want to wait after the tissue heals at least 2 to 4 weeks after the last radiation treatment. And then for the first month of this dilator use, it depends, but this is from a study. It was pretty aggressive in my opinion, but I won't do 5 days a week. I'll usually do every other day or even once a week starting for more like 5 to 10 minutes. But some patients would really, with a lot of tension, they may need to do this. This was from a study, but in real life, this might be, again, very difficult to fit into someone's schedule. So working with the patient on how they can incorporate this into the routine, again, maybe once a week or every other day, can be helpful. And then maintaining it 2 to 3 times a week, or I have some patients who just do it once a week for the remainder of their life, just again to prevent that tension. Again, there are lots of uses for vaginal trainers, but there are rectal trainers as well, which I have in my future slides. But this is more so to help with any kind of pain with intercourse or penetrative touch. And for patients who have had radiation therapy and have pain with penetration, specifically with female anatomy, there's other products. This is called an O-nut, but it's kind of like a silicone buffer. So it would go around the male anatomy, the penis, and it would shorten the depth of penetration. So for my patients who've had radiation therapy and they find that it's really uncomfortable, or even just after surgery, it doesn't even have to have radiation, working their way with their partner to gain the depth little by little, there's a product for that. So this is called the O-nut. And again, it's just little rings that go around the penis and then will kind of help buffer the depth over time. And this is from Intimate Rose. They have now rectal dilators. My patients who've had colorectal cancer and radiation, sometimes again, their stools will be very pencil thin. And sometimes that's due to muscle tension or also the side effects of radiation. So we'll work on stretching that area with this dilator. And you can see it goes in different grades depending on a person's body build, their anatomy, and we can slowly increase the grade. And usually the stretch is going to be for 1.5 minutes to 2 minutes. And again, incorporating that diaphragmatic breathing just to get that movement again back into the tissue. So like I mentioned, there could be a whole nother hour talk, but I did want to talk about some ostomy care and talk about prehabilitation of those muscles, specifically the abdominals and the hips, and of course the pelvic floor. And we'll touch on a little bit of this ostomy care for hernia prevention and before reversal. So there are some studies out there that looked at prehabilitation, but we need more studies. But this study looked at cardiopulmonary exercise and some resistance training, and now how that can improve the physical condition in older patients before going into surgery, which makes sense, but it's not always talked about or prescribed. So I wanted just to say, if you are having a surgery and you just want to prepare, you have some time. Again, this study looked at an average of 21 days to 41 days pre-op, and participating in cardiovascular exercise. It could be biking, swimming, walking, and some resistance training you can use weights, you can use resistance bands. It was 3 times a week, 20 to 40-minute sessions each time. They had significant improvements in their physical condition prior to surgery. So going into surgery as strong as you can and as healthy as you can will help with your post-op recovery. Same thing as far as patients who are having ostomies, and I have a lot of patients who come in and they say, I want to get back to exercising. I don't know how to strengthen my abdominals. Our deep abdominals are so important to our spine health and our core, our back. So they'll be complaining of hip pain or pelvic pain or back pain. And it's because of that weakness in their abdominals. They may not know how to begin that or how to do that safely. So we can work on how to strengthen their deep abdominals at first, how to incorporate their breathing, and then slowly build up their progression to whatever they want to get back to. It may look like doing some core marches, just marching on their back with their abdominals engaged. It may look like incorporating their pelvic floor and their deep abdominals when they get up from bed, how they move out of bed, how they lift, how they carry things. But it's all patient specific. But when it comes down to it, it's how can they regain that motor plan of how their deep abdominals will turn on during those movement patterns to provide additional support, especially along that incision. Because you can see here some of the risk factors for developing a hernia along that incisional site are here, and then they can develop early on within 8 months post-op. So really working with a PT as soon as you can after surgery, once everything is healed, is going to be so important. Sorry, it's a little blurry, but I wanted to include what I meant when I say deep abdominals. This is that muscle, the transversus abdominis, which is here. So it's not the 6-pack muscles or the rectus abdominis, it's not your internal or external obliques. It's the deepest muscle that, again, attaches all the way underneath your rib cage to your pubic bone and pelvis into your spine. And finding that muscle, it's such a small movement. That's why PT can really help you isolate and find that muscle. You want to imagine like you're trying to draw your belly button in towards your spine, and you might feel your back engage, your back muscles engage. This is literally your inner corset and the muscle that we need to train first before we do all the sit-ups and bigger muscle training to really help prevent that hernia. And what it looks like in PT, we may, again, everyone has different goals, but it's going to be rethinking how you lift things, how you carry your groceries, even everyday activities like walking your pets. I had a patient try to walk her dog after surgery and felt like, oh yeah, like I felt a strain on my abdominal. So working up to those activities, whether it's, playing with your kids, carrying and loading your back, your spine, all of those activities take a lot of demand from the muscles. So making sure we help you get to that point to do these things again and prevent, again, risk of hernia is what's important. And then for those patients who are having potential upcoming reversal and ostomy reversals, again, I want to include a little bit of evidence, but again, looking at biofeedback therapy, that's what's been studied a lot. Sometimes biofeedback isn't available at every clinic. So working on the pelvic floor, but really having that feedback and knowing that your therapist is feeling the muscle contract and relax correctly, that you're isolating that muscle well, is really what is the most important thing. But there was significant improvement in maximum squeeze pressure that they found with biofeedback therapy, or the group that did therapy, as well as improvement in this outcome measure that looked at stool type, pad usage reduction, and lifestyle changes, as well as quality of life scores. And then based on our knowledge of exercise physiology and muscle physiology, how long it takes to build muscle and get really good control, we want to work with the therapist for 12 weeks prior to surgery, okay, if you can, in an ideal world. Sometimes this doesn't happen. Sometimes I see patients 1 to 2 sessions even, and even that little bit of training can make a difference. Again, I'm going to circle back to that first statement I had, was that only 1/3 of patients will discuss or seek care post-op about bowel problems with their provider. And this is from a study. They talked about maybe it's due to the lack of awareness that there even is help for this, or maybe it's also some of the challenges around stigma related to discussing bowel issues. But hopefully now, after this talk, now you have a bigger picture of what pelvic floor physical therapy provides and how it can help. And I wanted to include how you can find your local pelvic health specialist. This is through our American Physical Therapy Association. If they're a member of our national org, they will be listed here. And then there's another one, pelvicrehab.com, where you can search your zip code, your city, and find a pelvic health specialist in your area. Just again, because PTs, we all graduate with the ability to treat all the other joints and the head to toe, but these are very specialized areas, the pelvic floor muscles. And then I'll open it up to any questions. And thank you so much for having me. I'm really grateful to be a part of this discussion, this group. Thank you.
I think this was amazing, Dr. Johnson. Thank you so much.
Thank
So insightful and thorough, and you covered a lot, and I think it hits on a lot of different stages where we are. There's kind of a common question coming in through the Q&A, and to summarize it, I think people are wondering on like timeframes. So we've got a few different specifics, but you know, with rectal cancer, a lot of people are getting radiation before surgery. So I guess in general, when would you recommend patients seek out this therapy? Like before anything begins, in between radiation and surgery, after surgery, or is there a continuum?
Yeah, that's great. I actually, when I was doing this, preparing for this presentation, I read a feasibility study which looked at all those questions, and it was really interesting because there's a lot of things, moving pieces when it comes to it, but in an ideal situation, someone would have rehabilitation prior to radiation. So radiation can, again, because of the effects of radiation, potentially causing that tissue to become more tense or rigid. Working with the muscle before radiation therapy is the best timeline to do that. And then after, again, like waiting 2 to 4 weeks after any radiation therapy. But that ensures that we get that full movement of the muscle before the tissue goes through radiation therapy. Before surgery, abdominal surgery, especially if there's going to be any kind of excision, it's really helpful to have there's some screening that the medical group, that the physicians, the surgeons can do to identify patients who are a little more, the term they use in the journals is frail. So looking at frailty, whether it's from a decreased muscle or the opposite, maybe an increased BMI, what can we do to improve that muscle health and overall cardiovascular health? And those are the patients that they should screen and then send to therapy before surgery. The feasibility study that I read, though, it did have the very important part of like timeline. How quick can they, or how much time do they have before, to prevent spread? So sometimes it doesn't work out that way. Sometimes surgery is needed right away. But again, there's hopefully more of an algorithm that's going to be coming along where this can be an important piece of the total care during during this whole process. But definitely before radiation, and the research that is supported is before ostomy reversal as well for pelvic floor.
Okay. We had another question come in about rectal spasms. Anything I know those are painful. I've experienced those myself, folks. Anything they can do in that moment?
Yeah, those are awful. There's actual medical term for that. They call it proctalgia fugax, and it's this, again, uncontrolled spasm in the anus. Some patients, again, if it's very tense, the breathing is the first thing I'll tell them to do. So doing your diaphragmatic breathing, thinking about inhaling and allowing your abdomen to rise and fall is one piece, but also thinking about inhaling and letting your pelvic floor descend as you inhale and then recoil as you exhale, but really focusing on that inhaling deep down into the pelvis that will relax the muscles. Sometimes I'll have patients put some manual pressure. So finding that tissue around the anus, and literally some patients of mine say they just intuitively do this. They'll hold and they'll kind of, just like if you have a pain, they'll kind of apply pressure, and that also might help allow that tissue to relax just by applying a little pressure and helping almost stretch the tissue. But breathing for sure, and then doing your manual pressure and stretching. All those exercises that open the pelvis, the deep squat, kind of lengthening the muscles, or a child's pose, if that's possible as well. All those things to help open up the area will help hopefully reduce the severity and the duration of that spasm.
Okay, thank you.
You're welcome.
Another question to the specifics of the dilator use during radiation instead of after radiation. It sounds like there's some conflicting ideas out there. What would you say, like concerns of using a dilator during radiation?
That's a really good question. So it all depends on how the tissue is. If the tissue is very sensitive during radiation, we'll just maybe, instead of using dilator, do some manual work. But if the patient can tolerate using the trainers during radiation, even a small one, that can make a difference. I know there are some surgeons out there who don't want any of that occurring during, and they say, let's just wait till after, for various reasons, but it can be sometimes a little harder to regain that mobility after, all the courses of radiation have been done. So I think it is really patient specific, but as far as I've read in the literature, there's no big, the only contraindication is if there is an infection or a wound to that tissue, that we don't want to do any kind of further dilation of that tissue or stretch of that tissue. So just as long as that's not happening, then it should be okay to do some internal treatment. Again, I usually want to communicate to the surgeon, to the physician, that we want to do this, especially if they're having voiding dysfunction or more tension that's lending to more bowel dysfunction, before doing that, just for clearance. So I think that's also another guidance to talk about with their therapists. Yeah, a really good question, because there is conflicting information on
That's
there.
Fong's question. Shout out to
Fong.
Fong for connecting us.
What?
This is Fong's doctor, so thank you, Fong, for connecting us with her. Okay, this is a twofold question, and Fong actually sent this one too, but I had the same question as far as like twofold. How long does this last? Is it like days, weeks, years? And then also several people are asking, is it ever too late? So maybe surgery was years ago. This is the first time they've ever heard about this. Can they start now? So yeah, okay. Frequency, like how long does it last? And two, is it ever too late to start this?
So I'll clarify question. How long does therapy last?
Yes. Like,
Oh, yeah.
is it a few sessions, or do they go on for months or years? Like, what does treatment kind of look like?
Yeah, that's a good question. It depends on the patient, to be honest, but treatments are usually we usually start off once a week, 45 minutes to an hour each session. And I'll see a patient at minimum 6 sessions, and then it may progress to every other week or once a month, working up to maybe 12 sessions, just to make sure, again, there's good progression in their program. For my patients who are still undergoing cancer treatment, I'm going to see them throughout that whole time. Like, we are a team. I'm not discharging them. So it depends on where that person is in their whole treatment and journey. But it's not unheard of for me to see patients, ongoing, maybe once a month, and just making sure, doing some check-ins, making sure that they're doing well with their home program, and then progressing it each time. Or sometimes patients have setbacks. So kind of being there to support them during that whole time. It looks a little different for sure than someone who's coming to PT for knee pain or for neck pain, where we kind of get them started, help them, and then they have a program they can continue. It's a different journey. So it can vary. It can vary from time to time, and it's never too late to come. So it's true. Like, the person who said that, who had that question of they never knew this existed, I see those patients a lot, unfortunately, and it's thanks to people like Fong who spread the word, that they come and they find out about PT, or it's through a friend, honestly, that they first hear about PT helping this. So it's never too late. Come on in. We can help you. There's always things that we can help improve.
Awesome. Thank you for that. What about patients who aren't near you? And I know there's some websites you offered to find one. But I know from personal experience, I've actually recently been looking for this, and it's not the easiest to find, especially like somebody who's specialized. And so any tips for some people maybe in a rural area or in a community that it's not easy to find a clinic like yours?
Yeah, I hear you. It's definitely pelvic PT in general. There's not many of us, and there's not many of us who've gone through all the training. Like, I have my board certification, and I see the need. That website is one way. Those websites are one way, but I think even talking to, if they have a PT or a local PT, if they know somebody, so sometimes through that network, there's other options. Thankfully, silver lining of the pandemic has opened up a lot of telehealth. And so telehealth, from like an education standpoint and exercise standpoint, just not the hands-on standpoint, can be a starting point for some people, to get help. I'm hopeful. I'm actually just starting a residency. It starts a pelvic health residency here at USC that starts this November. Our first resident starts, so that we can have better, again, training for these PTs, new grads, people who just want to get into pelvic health. So hopefully more interest will come, and again, more training will come, so that we can reach more people. But in the rural areas, even in California, like, sometimes we'll see patients via telehealth, and even that little bit of knowledge sharing through a telehealth platform can be really helpful. So even doing that can be a start if there's nobody local to do the hands-on treatment.
Yeah, thank you for that. And I'm so sorry, everyone. I can't get to all of your questions, the specific ones, and I know we're at time. But I just want to offer encouragement as a patient. I'm about 4 months post-op, and I just had a permanent ileostomy, the Barbie butt surgery that we like to say. And I consider myself a pretty well-educated patient. I work at Fight CRC, help put on these webinars, and I've had a really hard time finding somebody in my local area. And I've had to advocate for myself and ask for a PT referral and search around and call around. So just want to encourage patients watching this, it should come up more, especially if you're getting radiation, like rectal radiation and surgery. Unfortunately, it didn't come up for me in any of my surgery conversations of like, hey, you should consider this before surgery or after surgery. So hopefully this gave everyone tools to advocate for yourself, rewatch this, share these slides with, your teams, because this is really important. And we know a lot of you out there are suffering. And so this is one of several things we're going to do to try and help you with that. And we will definitely get Dr. Johnson back to keep talking, because I'm sure we could talk for the next several hours about this.
Yeah, I'd like to take time to thank both Dr. Johnson and Danielle for joining us today. Dr. Johnson, we really appreciate your expertise and sharing your time with us. I've received lots of good feedback already. And to everyone who didn't get their question answered, I do apologize, but we will definitely be hosting more material on this in the future. So please keep a lookout for it. If you'd like to continue the conversation, I did place a link for the Community of Champions app in the chat, and that will help you register for the Guide in the Fight meetup on September 14th. But after that, we will we'll be working on putting in more information out with this in the future. So thank you everyone for your participation. Danielle, Dr. Johnson, thank you so much again. And I'd just like to share Fight Colorectal Cancer's mission statement before we go. We fight to cure colorectal cancer and serve as relentless champions of hope for all affected by this disease through informed patient support, impactful policy change, and breakthrough research endeavors. Thank you all so much for joining us, and thank you to our panelists for the awesome webinar. Thanks so much. Bye, everyone.
Thank you so much.